Welcome back to Hot Flashes and Cool Topics. Today is a really important conversation that we are having with Claire Gill, who is the CEO of the National Osteoporosis Foundation. Welcome, Claire.
Well, thank you so much for having me.
Well,
We are so happy to have you. Yes.
We
Such
have a lot
important
of
topics.
questions from our listeners, from ourselves. Bone density, bone mass is so important, and so few people really understand what's going on. Can we start at the very beginning and talk about bone mass and the loss of bone mass and things like that?
Yeah. Well, we should start at the very beginning, because a lot of what we talk about at the National Osteoporosis Foundation is that osteoporosis is really really a pediatric disease that manifests itself as we age. So we build all the bone we're going to get, the densest, strongest bone we're going to get by the time we're about 25. So
Wow.
building bone and getting to what we call peak bone mass is really childhood, adolescence, and young adulthood, right? The rest of our lives, we are maintaining that bone density, right? It doesn't get any more dense than when we were 25. We
Wow.
just, again, build and rebuild tissue. So most people don't know too that our bone is actually a living tissue. It has a cycle system. We lose bone and then we create bone, and that kind of system happens throughout our lifetime. So again, we get to 25, we've got the densest bone we have, and then through exercise and diet, healthy nutrition, we maintain that bone and kind of continue to keep as strong as we possibly can. And then when we reach midlife, right, what we're talking about now for women at menopause, we lose bone because of our estrogen loss. So when we cease our menses, estrogen drops, as you know, and then we can lose up to 20% of our bone mass in the first 5 to 7 years postmenopausal. So that's why we sometimes think of this as a woman's disease. It's just because it happens so dramatically for women at midlife. Men too lose bone. It tends to happen a little bit later for them. Around 70 is when it starts to be a little bit more increase. And what that is really, like I said, the bone recycling. We're losing bone faster than we're making bone. And so that's what causes the low bone mass. So, it's again something that we should think about our whole lives, right? As parents, we should be making sure our children are growing and getting all the calcium and vitamin D they need and the exercise they need to reach peak bone mass. And then, like everything else in life, what we want to do to prevent heart disease and cancer and diabetes, exercise, diet, healthy diet, all of those things are important too. But we worry more, it seems, about our heart and about cancer and about diabetes than we do about, am I going to be mobile? Am I going to be independent the rest of my life? And that really is hugely dependent on our bone health.
Wow. That is, when you were talking about that, you said the 20% of bone mass when they people hit menopause. Does it compound, like as you get older? Is there more, that keeps adding to the 20%?
It really just depends again on how your body is remodeling, right? If you're still making enough bone and losing bone at a good rate, a normal rate, then it's fine. But because of age, we all start to dip a little bit, right?
Mm-hmm.
So that's often when people think, oh, it's just old age. This is going to happen to me no matter what. It's actually not. You could be 80 and fall and you shouldn't break a bone, right?
Mm-hmm.
It's only if you have bone health issues that you're going to break the bone, So that is something.
That is so much information that's important in the first minute of our interview that it's true. You kind of have to absorb all that information because you don't think about bone health with your children that much. You just think they're outside playing, they're fine. They're going to break a bone. They're, on the trampoline or they're on their skateboard or something. But you really don't think about how you need to start from the very beginning to create healthy bone. What can we do in those beginning years and even now ourselves to help to create healthy bone?
So again, it is the impact exercise, weight bearing exercise is the most important for building bone as far as exercise, right? We need the two kinds, the weight bearing and muscle strengthening. Muscle strengthening obviously is to protect the bone, right? And keep it in place and as safe as it possibly can be. But to create that bone and to create that formula and that recycling of bone, you need impact exercise. So we're talking about walking, running, dancing, hiking, Zumba, whatever it is you want to do, as long as you're on your feet. Swimming and cycling are fantastic for cardiovascular health. They do nothing for your bones. right?
Okay.
So many swimmers and cyclists end up with osteoporosis because they did not get that. They have fantastic cardiovascular health. Their bones are terrible, right?
Wow.
So
Oh,
find a lot of
okay.
professional athletes, a lot of cyclists will have issues with their bones. So that's something, again, you can, those are fantastic exercises, obviously still do them for your cardiac health, but you need to make sure you're getting the impact exercise, the walking, the running, the hiking, the dancing, etc., to be able to make sure you're building bones. That goes across the lifespan. So from early age, if you're looking at your children, you need to make sure that they're doing that kind of exercise, right?
Oh,
Jumping,
wow.
running, all of those kind of things that they need to be doing. And then we need to maintain that, for all of us. And then the weight bearing is important, as I said, and then muscle strengthening. So as we get older, and particularly as we talk with women, sometimes women are scared of weights, right? Do not be afraid of weights. You are not going to turn into a bodybuilder by lifting 10 pounds of weight, right? That
Mhm.
kind of muscular that we want to be saying feminine, and we don't want just a muscle show. I think some of us are moving away from that. I think we're all starting to see when we look at J-Lo, like, oh, those muscles actually look really good. But that's really important for all women, right? That we need to have some of that, weightlifting kind of stuff to intensify and make sure that our muscles are really nice and strong. So
Mhm.
those are the two things. And then the balancing type exercises. So all the things that help our core and our stretching, yoga, Pilates, etc., are all great because they help us maintain balance. And as we get older, not falling is one of the most important things we have to do. Staying up
Right.
is so important. You can have low bone mass and osteoporosis. If you don't fall, you may be lucky to never have a bad experience with it. But for some, depending on the severity of it, it doesn't even take a fall. We've had patients who sneeze and break a bone, break a rib.
My gosh.
Some
Wow.
hug them gently, and they broke a rib. I mean, really, it can be very fragile. So it really depends on the person, and it's unique for everybody.
What
Right. So,
about what
oh,
you can,
go
oh, I'm
ahead,
sorry.
Colleen.
I just
That's
wanted to
okay.
finish in that line of, okay, so weight bearing and strength training. What about diet?
So diet and is important in that we need mostly calcium and vitamin D. There's tons of nutrients that are good for bone health. And if you eat enough fruit and vegetables, you should be getting plenty of those. Where we tend to fall short is in calcium and vitamin D. For calcium, that's obviously a huge portion of what our bones are made up with, like our teeth, right, are made of calcium. And so again, it's the recycling and the calcium absorption that starts to delay as we age, and we have to make sure that we maintain our calcium intake. We recommend at the National Osteoporosis Foundation that you try to get all your calcium from food first, right? And then only supplement for the shortfall in your diet. So if again you're having dairy or yogurt, cheese, milk, etc., all of that is really good. For women under the age of 50, they need 1,000 milligrams of calcium a day. And for women over 50, it's 1,200 milligrams. And those numbers are the same for men. It's just at the age of 70. 70 and younger, 1,000 milligrams. 70 and older, 1,200 milligrams. So,
Wow.
for example, we got to pay attention to our diet. If I have a yogurt in the morning and I have some cheese in the afternoon and I've got like 600 milligrams and I'm trying to get to 500, but I just can't get any more in my diet, then I only want a calcium supplement that has 500 milligrams, not 1,000 or 2,000, right? You're only supplementing for the shortfall in your diet. So you need to know and keep track of how much calcium are you getting from your diet. And if you think too, today we have a lot of fortified foods. So if you're drinking orange juice with calcium and vitamin D in that, you need to read that label. You've gotten some calcium and vitamin D already. If you take a multivitamin, you've gotten some calcium and vitamin D already. So trying to keep track of those kind of things. If you do that for a little while, you'll start to realize, oh, I'm pretty good. I get it pretty consistently in my diet, or man, I'm way off and I have to start thinking about
Is
that.
is there any danger in having too much? Like,
There is, right? There is some
okay.
danger, but it's really higher upper limits, right? You need to kind of
Okay.
be taking in a lot of calcium for have it start to be detrimental to you. But we
Okay.
really try to say stick to that 1,000 to 1,200, right, as best you can. Getting more calcium doesn't do you any good, right? It's
Okay.
not like, oh, I'm going to have a little bit more then. No, 1,000 to 1,200, that's exactly where you need to be. So don't go too far over that if you can avoid it. For vitamin D, it's a little harder. You can get it from the sun. Obviously, that's the natural way to get it. But we would need to be outside 30 minutes a day, year round, with our face, arms, neck, legs exposed.
Oh,
Not
okay.
many of us in this country are able to do that. So you can get it from your diet, but again, it's a little harder. You need to be able to eat like sardines with the bones in. Not sure
We
many.
have to.
If you want to get your vitamin D
Right.
naturally, those are the kind of things that you can do, right? And there's other foods, but again, you're also in the fortified orange juice, you're getting some vitamin D, all that kinds of stuff. But most of us have to supplement. And again, it's a little different on vitamin D for men and women, in 50 and under, they only need 400 to 800 international units of vitamin D. So again, don't get 1,000 IU supplement.
Okay.
If you're under 50, you only need the one that says 400 to 800 or 400 to 800. And then again, if you're older, it moves up to 800 to 1,000.
Okay.
And that's really every day. That's consistently. That's what our bodies need. And I think, many research studies shows that we're all vitamin D deficient, so
Mhm.
I clearly am. You can tell by the pale skin, right? I'm not getting it from what I need from the sun. So that's something that I have to be very careful of and make sure that I maintain. But even people, even African Americans can be vitamin D deficient, right? It doesn't have to do with the skin tone. So it's really very personal. It's a blood test that your doctor can give you that tells you whether or not you're deficient in vitamin D. And then making sure that you get that daily is really important. So again, healthy diet, everything that we do that we should be doing for our overall health, right? Eating
Mhm.
vegetables, limiting proteins, doing all this kind of stuff, not drinking too much alcohol, no smoking, right? That's just bad all around, but it's also bad for your bones. So we want to avoid that as well.
Do you think, okay, so I found out, and Colleen has her own personal story too with osteoporosis. I went to a women's health fair one time, and they had the little bitty machine where you put your foot in, and it was really horrible. My reading was awful, much worse than any other woman I was around. And so I made an appointment. I was not 50 yet. I might have been 43. And I went and had a bone scan,
Yeah.
and it was fine. Everything was fine when I had the bone scan. And that was usually earlier. What is the age that they recommend a bone scan, like a baseline? And then what do you think the age should be?
Well, yeah. So the recommendations differ
Mhm.
depending on who's recommending it, unfortunately. But if, like I said, if you are over the age of 50 and you fall from a standing height and break a bone, you should have a bone density test, right? So that's where we get to the thing. For most recommendations, that 65 women should have a bone scan if they haven't yet. And for men, it should be 70. That's what's covered by Medicare, right? You're welcome to Medicare packet. You can have a bone density test. However, if you have a family history of osteoporosis bone loss, so think about it. Did your mother, your aunt, your sister, your father, your grandfather, anyone in your family break a bone over the age of 50? Whether they got diagnosed or not, good chance that they had osteoporosis. It's 90% heredity. So we can do as much as we want to protect ourselves and do what we do, but unfortunately, this is it. You can tell a lot by what happened in your family. So if you know that family history, that's great. Unfortunately, some people, for parents who didn't live that long, there was no way for them to know
Right.
whether or not that was an issue. So yeah, so we have to present that. That's one of the big things that's specific for our institution is if you fall from a standing height over the age of 50, ask for a bone density test. And your doctor should be able to pull together the risk factors that will get that covered for you. As you know, it's a non-invasive test. You lie down on a table, it scans you, it can tell, very accurately. I mean, the DEXA that you had, the follow-up, is the gold standard, right? It is the most accurate test that we can get. And again, it's non-invasive, easy to do. The heel scans are a little, again, controversial. It depends on the person doing them, if they do them right. There's also some finger tests. And we kind of always say to people, that's good maybe to gauge your rain, like a screening, but you really need to follow up. And actually, you can't diagnose with one of those tests. You can only diagnose with the DEXA, right? The full bone.
And I had also injured that foot previously, so I don't know if that had something to do with it or not. Yeah.
Right? Yeah, it can
Mm-hmm.
be very different. So it's really important. I mean, again, it's really good for screening purposes. We like people, at least that you got awareness about bone health, right? When someone says, oh, put your ankle here and talk about your bone health, you probably are like, oh, I've never done this before. So
Yeah.
in that respect, it's very good, but it's always good to follow up. When you get one of those tests, take that to your next doctor's appointment. Say,
Mhm.
I did this. What do you think about this? And
Yeah.
hopefully you'll be
It-
with a physician who will know, which is also
Mhm.
a concern because many don't. And,
Mhm.
or they'll refer you to someone who does.
Yeah. Mhm.
Well, it's interesting because with my own personal experience, my mother has osteoporosis. I never really thought about it. And with the exception of an occasional toe or finger, I'd never really broken a bone. And when I turned 50 or maybe 51, I was walking my dog and literally stepped off a sidewalk and broke my foot, fractured a bone in my foot. And the doctor said it was a pretty severe fracture. And I'm like, I just was walking the dog. And so I was in a cast, the whole 9 yards. But my doctor said, you know what, let's just do the scan to get a baseline to see where you're at. And I was diagnosed with osteopenia or penia,
Mhm.
and didn't realize that hereditarily I was kind of doomed because my mother has it, my sister has it. Um, so with it being 90% hereditary, that family history is so important. It was shocking because being a Pilates instructor, I thought, oh, I do all weight bearing exercises. I had done the stuff that you had talked about before,
Yeah. Yep.
but I hadn't really put in the hereditary component. And I
Yep.
don't know that a lot of women do.
No.
Once you get that scan and they say you're either have low bone density, what can you do at that point?
So the same thing, it's diet and exercise. It's kind of increasing those. But exactly as your experience, I hear from so many patients that are just like you, where they're like, I did everything right. I'm healthy. I'm the right weight. I've been doing exercising my whole life. I get plenty of calcium and vitamin D. Yet I have osteoporosis. Why did this happen? And unfortunately, it's like I said, there's some things that we can't change. Being small framed, right? I was joking like I'm a big bone girl, and finally something decent for big bone girls. But my mother had osteoporosis. My mother broke her hip. So again, it's going to happen for me, and I need to do what I can now to protect the bone I've got. So that's it. But when we talk about and discuss treatment options with patients, again, most patients want to make lifestyle changes and fix it, right? And that makes perfect sense. And those lifestyle changes are essential because even the medical treatment doesn't work as well if you're low on calcium and low on vitamin D. So you need to be able to do all of those things. But for some, it will take a treatment, a medication. And we're lucky that the treatment that's available these days can protect bones and prevent fractures by up to 70%.
Wow.
And again, when we talk about think about any treatment where you're like, oh, it's 70% successful and, keeping, the worst case scenario away. And for osteoporosis, the worst case scenario is breaking a bone or breaking a hip and then potentially dying from it or becoming immobile, right? And having to be dependent the rest of our lives. So again, definitely talk to your doctor about treatment. But for most younger people, and again, people think the first thing that's going to be recommended to you is calcium, vitamin D, weight bearing exercises to see that. And they'll just monitor you and see, are you okay? You've got low bone mass, but are you still staying at that level and continuing to do those things? Then they'll probably just continue to monitor you until it starts to drop off more severely. And then you might need, medical treatment and do that. But for some people, again, depending even younger than 50, you just don't know. And again, I've had, moms reach out to me where they got osteoporosis, lactation osteoporosis, right? Can you imagine you're trying to take care of
Wow.
the baby? They can't pick up their baby because they'll break a bone, and I'm like,
Wow.
God. There's younger women, people talk about some of the other kind of diseases or conditions that contribute to osteoporosis or can lead to osteoporosis. So celiac disease, right?
Mhm.
Malnutrition kind of thing, and that can also impact your bones. And many people with celiac also need to check for bone density and monitor that as they go on. Irritable bowel syndrome, people who have conditions that require a lot of prednisone, a lot of steroid. They will,
Mm.
again, steroid saps the calcium from your bones and makes them less dense. And so therefore you
Ooh.
might have to do that. So it's hard to think about when we're dealing with all these other things. I know, like, if you have multiple sclerosis and you're diagnosed with multiple sclerosis, the last thing you want to hear is, oh, and by the way, the treatment for this is going to lead to another chronic condition. But
Wow.
the reality, and same for women who survive breast cancer. Once women survive breast cancer, the treatments for many breast cancer chemotherapies will lead to osteoporosis. So lots of programs being done now to try to help educate women with cancer about the fact that they probably should all have a bone density test after they're done with treatment, and then, you know, deal with, again, what comes after. Yeah, diabetes, people with diabetes tend to be more prone to osteoporosis as well. So we have a long list on our website at nof.org that talks about, you know, both conditions and other drugs that can impact your bone health. So really, again, the most important thing is to have this conversation with our doctors, right? We're talking about our heart health, we're talking about our weight, we're talking about our cancer risk, all of these things as we age, and then we don't talk about bone health. And unless you have a physician who knows enough about it to say, as you did, Colleen, hey, I think you should get that. When I heard that story, I was really happy for you because, you know, as I said, the statistic is that 80% of people who fracture a bone due to osteoporosis never get any follow-up to find out if osteoporosis was the underlying.
That's insane. That's just, you
That
know,
is insane.
it's
Yeah.
kind of like when we talk to doctors who specialize in menopause and say that most doctors don't know, OBGYNs don't know the information or aren't up on the latest statistics and testing. It sounds like we're behind also on our knowledge on bone health.
It is, but you know, it's the same thing. And it's exactly, as you said, the similarities between osteoporosis and menopause. One of the similarities is no one owns osteoporosis in the medical field, the way they don't own menopause, right? So for osteoporosis, you can go to your primary care, you can go to your gynecologist, a geriatrician, an endocrinologist, a rheumatologist. All of these people can treat osteoporosis. So it's not like with cancer, you go to an oncologist, right? Or you have heart issues, you go to a cardiologist. Nope. Anybody can treat you for things. And then the most complicated part for me as a layperson, when I joined this field, is all of those professional societies all have guidelines that differ on when to treat, how to treat, who to treat. So again, it depends on who you see. You might go to your primary care and they say you're fine, and then you go to an endocrinologist and they're like, no, you meet the criteria based on our things and you should be treating. So we're doing a lot of work at the National Osteoporosis Foundation to train primary care physicians primarily, right? Because those are our first frontline workers, right? They're the people that most of us see. And to try to get them to understand how much, you know, what are the risk factors? What do they need to do? And as you all know, we have 15 minutes with our primary care doctor now, right? They're dealing with the most pressing issue that you have, whether it's your diabetes or your blood pressure or your heart rate, all that kind of stuff. Whether or not you might fall and break a bone falls lower on the list of things to talk about during that visit. I tell people this story, as I had shared with you earlier. My mother broke her hip at 83, and she was a retired nurse, and she tripped over a cord at home, and fortunately had great surgery. They repaired it. She worked her butt off in rehab, and she, you know, ended up, you know, surviving, thank God. Because as we talk about, 25% of people who break a hip die within the first year after the surgery. So my mother did end up, the other 50% end up with an ambulatory, right? A cane or a walker. And that was my mom. She had to start using a cane. She hated the walker. You know, eventually we got a little wheelchair that we could pop her around in, but my mom was non-compliant on her medication. I took her to see one of our trustees. They all told her, you have osteoporosis. She's like, you know, it's fine. So I tell people, I can't even convince my own mother.
Wow.
We're all on the same boat. She'd lost 3 inches of height, which is another indicator, a risk factor. If you lose more than 1.5 inches in height, that is likely because you've had compression fractures in your back, and they've compressed and you've gotten shorter, right? We all lose a little bit of height as we age, but you should not lose 3 inches of height, right? And that's also what that you might see the older
Bridget's mouth.
Like, I don't want to lose any more height.
Right? But you see older people when they're stooped over, right? That we always think that's terrible. That's kyphosis. That's from fractures in the spine that were never treated and helped. And that causes, again, digestive issues and breathing issues and all kinds of stuff. So again, it's just really important, but we have to convince people that this isn't a normal part of aging, and that we should take steps to, you know, take care of our bones from you know, early age on.
Wow. So is the other 25%, do they come away from a fracture without any assistance, or what's the other 25?
They end up in nursing home or assisted living.
Oh, okay. Okay. Wow.
And when you first mentioned that statistic to us, and it was so shocking, you also mentioned that that's not just a statistic for older people. That's 25% of
All people.
everyone, all ages.
Yeah. Yeah.
That's,
Tends to be older people, right? If you look at the statistics, it would tend to be older people because they'd be more susceptible to those digestive respiratory issues that happen, right? And so therefore that's it. It's not likely that the fall kills these people. It's trying to recover from that fall is what ends up killing people, right? And so that's what we say, about 25% die within the first year because they're not able to recover from what happens post surgery. And then we said 50% end up with a walking cane or, whatever they do. And my mother said the same thing. I just tripped and fell. It's like you said, Colleen, oh, I just stepped off the curb. Yeah, that was totally normal. It wouldn't have happened otherwise. Well, you shouldn't have broken the bone when you fell.
Right, exactly.
And that's the issue. And that's, again, what the treatment is supposed to do and why we do balance exercise and all that. It's really to prevent falling and fracturing, but again, we can't guarantee any time in our lives that we're not going to fall, right? So that risk is always really there and we have to be very cognizant of it.
Is there, once you've been diagnosed with low bone mass like osteopenia, but you haven't reached the numbers for osteoporosis, can you stay in that range if you're doing everything that we talked about, the diet, the exercise, and never reach osteoporosis?
Yeah, hopefully for people that would be it. Your instance though, Colleen, one of the things that we worked on with a coalition of organizations in the bone health field is to diagnose that although your test showed you have osteopenia, because you were over the age of 50 and fractured, by our account, you have osteoporosis.
Oh, thanks. Yeah. Okay.
So if you went to one of the clinicians within our sphere, they would tell you actually have osteoporosis.
Osteoporosis.
You had low bone mass, but you had that fracture. Fracture begets fracture. Your most important thing now is to prevent future fractures. I'm sorry, this is really not good news for you, but your rate of fracture, your risk of fracture has increased 3 to 7-fold because you've had that first fracture.
Then my husband should walk the dog all the time. I can't.
That's right. I have some bubble wrap. I'm just going to come over to your house and wrap you up.
Bubble wrap. We said that a million times. Like people can you make sure, just keep them upright? Yeah. So again, but that is exactly right, Colleen, as you've experienced, right? Some people, if you go to one expert, they're going to tell you have osteoporosis, and you go to your doctor and they say you have osteopenia, you're good, whatever. But again, the fact that you got a test in the first place is fantastic.
Right.
Wow.
And then, and now you just got to be really mindful of, having that conversation with your doctor and monitoring yourself to make sure that you are staying in that lower range and that you're doing whatever you can not to fracture.
I think it's really important for anyone listening, man or woman, to know that you should have, we talked to Joan London and she has like a file of every doctor that you don't think about as you get older, but that you need: your eye exam, having your, skin checked, having your bone density checked. And it's really important for people to realize that it's not just about going to your primary care physician, that you have to check everything. You have to be your best advocate.
You do.
Because like you said, it was the luck of the draw that my doctor happened to say, you're over 50, let's have a bone density test. Some may not have.
That's right. That's right. And the same thing is for those of us that are caregivers, right? If you, again, with my mother, she would never have initiated herself. Her doctor didn't initiate it. It was us going, look, we need to go follow up on this. This is happening. This is what needs to be done. So for all of us, again, at midlife, if you are there and are lucky enough to have, your parents or anybody else elderly in your family or your community that you're looking out for, that's another thing to consider. Have they had a bone density test? Do they know where they are? Have they had any falls? If they do have a fall and fracture, make sure they get a bone density test. Push for it. As you said, these days when it's so difficult within the healthcare system to navigate through, even for those of us who work in it every day, it's really complicated. We say that all the time. My siblings and I, my brother's a lawyer, my sister's like an IT, person. I'm in the healthcare field, and navigating that for our mom took a lot, right? So what happens to people that don't have that kind of support, right? They fall through.
Right.
And those are the kind of people that we all have to watch out for.
Right. And one of the things I want to mention also on your website, you have like a peer conversations where you can actually, if you have questions, you can go into this community, and there are other people who may have experienced what you're going through and they have great advice. So your website is full of wonderful information for
Thank
people that maybe don't know where to go or what
Yeah.
to do. So I would, Bridget and I would both recommend that everyone check
Mhm.
out that website.
Thank
You
you.
know?
Yeah, there it is. It's a ton of information. Sometimes I even have to type what I'm looking for into the search bar because, navigating through all of the details are in there. But you can always, again, send an email to info@nof.org, and someone on our staff will respond and help you navigate and get what you need, the information you need. So as you said, I really encourage people to go to the website, and that online community you're talking about. We have almost 60,000 people now that are
Wow.
here, all peer-to-peer support. So again, it's a great opportunity to go on there and sort of find out, well, what are other people experiencing? I also caution people, though, to take it with a grain of salt, right? Everything is personal, and I found for another medical condition that I have, when I went onto those communities, I was like, that's not me. I'm very positive and I'm going to do well with this. And I don't want to spend time talking to people about how woe is me,
Right.
Whereas I find these peer-to-peer things invaluable for most people. I would say just find the right people on there that are going to be following your mindset and, being positive like you are if you want to. Or again, some people who want treatment and want to talk about treatment. And then you have people who are like, I would never do that. It's terrible. Don't take any drugs. Again, find your people and then, circulate within that.
Right. I'm so glad you said that, because so many people go to Dr.
Dr. Google.
Dr. Google, and then you're just terrified, or you're like, like you said, you're like, oh my gosh, I'm going to be gone tomorrow. So that is very important. I'm so glad that you said that. And it's so interesting, the whole bone scan thing. Colleen and I interviewed a woman a few months ago that had breast cancer, and they found it through a bone scan. She had had a mammogram, clear mammogram 2 months ago, and her doctor just said, hey, let's get a baseline bone scan. She had
Wow.
even had the ultrasound, and the bone scan found her cancer. Like, the person who did her scan thought she had bone cancer and was like touching her shoulder. Does that hurt? And she said, no, they found breast cancer through her bone scan.
Wow.
It had
Yeah.
metastasized.
It had, but they didn't find it in the mammogram. So I just am always curious as to why bone scans are put off till you're 60.
Again, it's what the consensus among the medical community about what's right and efficient and makes the most effective use of the scan kind of stuff, right? So everything costs money. So they're not going to make, obviously, everyone do a test like that. It's the same way that we have recommendations for breast cancer, for mammograms, right? There's the standard, and then there's if you have a family history of breast cancer, right? Similarly, same thing with colon cancer, right? You're not having a colonoscopy,
Until you're 50.
50, unless in my family, my dad had colon cancer. We got the joy of it at 35, right? Because they start you
Lucky you.
on the bone scan earlier. So, so it's the same thing with bone density, right? It's 65 seems to be the norm, unless you've broken a bone over the age of 50, or again, you have other severe risk factors, right? It really is paying attention to that. You should be able to do it. But, talk about why we don't get the bone scans and stuff like that. And I say that to people all the time, because you both experienced, it's non-invasive. It's so easy. We don't have to take our clothes off or do anything, and no one does it. Right. But we line up for mammograms and for colonoscopies. And I said, I need to start telling people that bone scans are awkward and uncomfortable and painful.
They don't want to do it.
Line up, right? We'll be like, sign me up. So maybe that's the message I need to get out. I have no
Maybe
idea.
they like a challenge. I don't know.
The prep the day before is a nightmare.
Yes.
I mean, when you
They
think
love
about
drinking
it.
chalky substances. I don't know. Yeah.
So I don't know. I have to come up with a new message that will make more of us, inclined to go get it, because apparently it's easy and non-invasive doesn't inspire anyone.
It doesn't. Yeah. I think I was lucky as Colleen was, because I was like 43, and my doctor just said, hey, let's go get a bone scan after you got that little, they gave you the little, it's almost looked like a receipt.
Yeah.
Here's your reading for that little ankle thing.
Yeah.
And she said, oh, go get it. Right. Go over, our hospital had a radiology department. I just went, boom.
That's it.
It was,
Well,
yeah.
The other issue we're having these days is that the reimbursement rate for professionals to do bone densities has gone down so dramatically. Again, more than you need to know about all the policy and health policy, but basically they kind of about these formulas within CMS for what gets reimbursed at what rate and what doesn't. And although mammograms were pulled out, like as a woman's health issue, so it should stay as a priority, bone scans did not. So now the nationwide reimbursement rate is about $40, and it costs about $125 to run those machines. So,
Wow.
Wow.
so doctors stopped giving, like they couldn't keep it in their offices. So now again, you might have to go to an imaging center or to a hospital and all of that kind of stuff. So we've been working on legislation with a whole coalition again of people about fractures to say, look, this needs to be prioritized, and the reimbursement needs to be something that will allow people to give this test. That again, we know it can predict fracture risk. We know it can make a big difference. And so that's something that we're working on the policy side, because we've lost so many providers. And it's okay for you and me, like, right, the younger people will drive to wherever it is. But if you're an older patient and you've gone to see your doctor and now you have to go to another facility, and if you're in a rural area that might be miles and miles and miles away, they're not getting it. They're not doing it, right? Whereas they used to be able to do the one-stop shop, just move to the next room, get that test, you know, move around. That's what we're lacking. So again, that's part of the problem in the United States.
Okay.
When women and men have done everything right, but they still need treatment, medical intervention, what options are available right now that they could start taking?
Yeah. So again, there's a bunch of different categories within the medication and treatment, and that it's very personal. And we don't make any recommendations, you know,
Right.
from our association, but we do on our website have a list of every treatment available and what the side effects are, what's the right person. Generally, that's usually given is more for women, more for men, you know, that kind of stuff. What does this type of medication do? Like I said, some of the medications are meant to slow down the loss of bone, right? You're still remodeling the bone, you know, and doing that loss and gain, but you're slowing down on the gain and the loss is catching up. So there's some medications that go to stopping the loss, right? Trying to slow down that loss process so the body can catch up and remodel. And then again, for others where that's, you know, completely out of sync, there's now treatment that goes to both slowing down the loss of bone and helping turn up the rebuilding of bone and rebuilding again. And so it really depends on where you are. Like all treatments, there's oral treatments, there's injectable treatments, there's once a week, there's once a month, there's twice a year. It really, again, is so personal. And that's, again, something that we work so hard at our organization to do, is ensure that patients and physicians get to make that choice, and that it's not something that's dictated by our insurance or by Medicare coverage, right? You should be allowed to do the one that works for you. And, you know, again, like all treatments, I'm going to say to people, aspirin has side effects, right? So every treatment has a side effect, and it's finding the one that you tolerate the best, right? And kind of getting through that. And so, you know, that's another thing that was a big issue within the osteoporosis field, is about 10 years ago, it became, you know, people became aware of the fact that there were some rare side effects. And some of that, as you probably heard, is like the O&J of the jaw, like the jaw, the bone in the jaw maybe deteriorating because of the medication, or a fracture of the femur in the leg, right? That's due to some of the medication. Well, then that scared everybody off the medications, right? Because everybody knew somebody who had that rare side effect, and I'm not taking it. And so we spent a lot of time, again, talking about the risk equation when it comes to treatment, right? You need to look at your overall risk for fracture. And is the risk of you fracturing so much greater, and it is, than you having a rare side effect? Then you might want to consider that, right? Because like I said, there's a risk for any medication we take, and we all make that judgment. Oh, okay, I'm willing to do that. And then for those people who, again, have had multiple fractures and are in pain and want the fractures to stop, taking the medication is a no-brainer, right? It's for people, I really think a little bit more in your area, Colleen, where it's like, I've fractured, I've got low bone mass, you know, what do I do? That's a personal conversation between you and your doctor, whether or not the risk for you outweighs the benefit, you know?
Right. And, you know, just for information, what ended up happening for me is that we've decided every 2 years I'll go for a bone scan and see what's happening.
That's
So,
exactly.
I was very lucky to get someone who understood that
That's,
this needed to be checked out. But ask, if you want to know, ask your doctor. And if your doctor doesn't have an answer, find maybe another doctor who does, because they are out there, and there are organizations like NOF that can help you find information. So there's knowledge out there, and knowledge is power.
that's exactly
Mhm.
right.
Yeah.
Mhm.
And if you're not busy enough just with your osteoporosis organization, you also founded the National Menopause Foundation in 2009. And we want to make sure to make a mention of that. Can you talk a little bit about that foundation?
Sure. Yeah. Well, it's 2019 actually.
19.
Oh, I'm sorry. Yeah. Let me try that again. 2019.
There you go. Yes. Yeah. So the same thing. I was, working in the women's health field now, doing osteoporosis for about 6 or 7 years, and was approached by people who were sort of looking to reach women at menopause, but there was no national advocacy organization for menopause. There was like osteoporosis, and as we just discussed, there's such a link between osteoporosis and bone health. Osteoporosis and menopause as far as bone health. So I looked into it a little bit, and like I said, there's fantastic organizations out there, right? So it's the same thing. It's like, you need to know where to go. But there's a lot of clinical organizations that are out there where, professional organizations, as we talked about, for clinicians who are looking to specialize in menopause. The North American Menopause Society is there and has incredible information, both for clinicians and patients, right? But most patients aren't going to go to the North American Menopause Society, this professional society, for their information. I wanted there to be a true patient, like not patient, but women focused, right? One of the things we talk about is menopause is not a disease, right?
Mhm.
Just a
Yes.
life stage.
Yes.
So it's really
Mhm.
hard, right? We have a lot of work to do again as we talk about that. So anyway, I decided I'd been recruited by an organization to save the bats, right? So there's a national organization to save the bats, but there wasn't one for menopause. And found this hard to believe.
Yeah,
And
that's
so,
a hard one to wrap your brain around.
so I decided to start one. And so yeah, so we formed the National Menopause Foundation in 2019, in September 2019, and we're working to build that community and to help educate women. So we have a long URL. It's not like the NOF where we got it down. I have to raise the money to be able to buy the URL that like makes it smaller, but it is fully the National Menopause Foundation.org, and some great information there. We too have a podcast. It's called The Positive Pause, and a newsletter called The Hot Flash, all the things you need. But the goal of the National Menopause Foundation, again, is not to be the clinical, side of it. Like I said, there's really good clinical. I wanted to create a community where women could come to get information, to build that online kind of peer-to-peer support that we need, and to be empowered. When I talked about what we were hearing about menopause and about this stage of life, and it was like, kind of go off quietly now. Your childbearing years are done. Your usefulness is lessened, and I said to myself, my God, I've never done anything quietly in my life, and I don't
Not
intend
doing it now.
this.
Mm.
No way. And again, why shouldn't this be the most empowering and powerful time of our lives? Right? We're tend to be more at the top of our careers at this age, right? We're more powerful influencers. As we've talked about, our mindset changes a little bit, where we're much more advocating on behalf of ourselves. And so I wanted to inspire that for women. I wanted to kind of create that positive change and shift. And what's beautiful is that podcasts like yours and so many companies are finally coming around to the fact that, hey, this is an incredible demographic. We talk about 1.3 million women enter menopause every year in the United States.
Wow.
You
Mhm.
know, and when I developed this with my husband, God bless him, he was like really supportive, because I did it all on my own savings and my own time, trying to build this. And he's like, yeah, this is incredible, because like almost every woman goes through menopause. And I'm like,
Mhm.
it's every woman.
Well,
I always say, if you're lucky to live long enough, you're going to go through it. Yeah.
And that's the other thing to celebrate, right? If
Yeah.
Great, we've reached this milestone, and when you think about it, years ago that wasn't a given that you would make it to menopause, right?
Mhm.
So now we
Mhm.
are, and we're changing so much more. We're all living longer, we're being healthier, we're doing all that. I think that what aging looks like, and healthy aging is changing too. So you think about menopausal women now it's often joked about, and I'm sure some of your other guests have mentioned on previous shows about like the Golden Girls, 1980s.
Oh yes, oh
What a
yes.
menopausal woman will look like, right? And then today it's like, okay, Jennifer Aniston and J-Lo are menopause age, right? That's very different.
We just need them to mention it.
Yeah.
We need them to have a hot flash during an interview or on the middle of a stage and be like, hot flash.
That's true. But you know what? I think we will get there, right? There are
Yeah.
more celebrities talking about it, right? You can go
Yes.
online and find we talked about even in Sex and the City during the movies. Remember when Kim Cattrall was eating all of the thing of So it's there. And again, Sex and the City is coming back to talk about 50s.
And they'll be in their 50s. So
yeah.
So again, I think now is the time. We just have to push through to normalize this and work together to destigmatize what this means for women and what that looks like, and then inspire each other, right?
Right.
How do we use this next chapter of our lives? We celebrate when young women enter puberty, right? And there's little gifts you can get now. Welcome to puberty. I want a welcome to menopause packet.
Right. Yes. All those products
and stress balls, like great, we should have that.
Exactly.
That would be awesome. That's a great product. Yeah.
That's what we want to do and try to inspire that, and I talk about, again, we're in such different life stages of parenting and things have changed for women. And so I happen to be the mom of a younger daughter. And so she knew more about menopause than she did about puberty. It was calls it the menopause, like the British, which I just love. She'll see me sweating and be like, oh, mom, the menopause, But I'm normalizing that for her, right? And having a conversation when I fly off the handle about something really simple, I can go back and be like, you know what, that was a bit of an overreaction. I think it might be the menopause, right?
The menopause.
That's a conversation have with your spouse too, right?
Oh, absolutely.
Your partner. Hey, this is changing and it's thrown me for a loop and I know it's normal, but we're going to have to get through this together. Right. And we kind of have to make a few accommodations. And, and for some women I've heard from, they breezed through menopause. They never knew it didn't change them at all.
Yeah. We don't talk to those women.
But for the most women are, and then the extremes, is the, oh my God, it was completely debilitating. And that was really horrible. And so I want to be there for both those, for everything in between, right? And help younger women that, again,
learn
about, people don't even know menopause, right? Menopause,
right?
The day our menses stops for 12 months. Right. Everything else we experience before that is perimenopause, right? That's where we're really going through all of those hormonal changes and all of those things kind of stuff, whatever leading up to it. And no one tells women in their 40s.
No. Didn't hear about it while I was going.
You just call everything menopause. It's all, and you don't even realize the anxiety that goes with it.
I feel that peri is hell. Peri is much worse than post menopause.
Thanks, Bridget, because I'm still
sorry,
in
girl.
peri.
She's still going through it. But I'm like, Colleen, I'm telling you, peri is worse. I feel like for me, but that's personal, than post.
And that's again, for most people, again, even the experts will tell you the brain fog, the depression, the loss of libido, all of that will sort of taper off then post-menopause, right? You kind of come back to a little bit more. But that's for many women. I have friends in their 70s who say they still get hot flashes. And I just, oh my God, I'm like, gotta be kidding me. But that, again, it's really, like you said, it's really personable, but we're not talking about it. And so then again, when women are having all of these issues in their early 40s, and it could be 7 years till they're actually menopausal, right? So what is that beforehand? And having that conversation with the doctor to say, hey, what's going on? Again, women's health, we poo-poo it. It's not important. Oh, just deal with it. Or they'll say, oh, it's menopause.
Yeah. Oh, it's normal.
Just. We spoke with a doctor.
And how are you going to help me? Right. And what are you going to do about it? Right. And then the other disservice we did again was, hormone replacement therapy and what happens with the Women's Health Initiative 10 years where they raised great concerns about breast cancer and heart disease. 10 years later, it was wrong. Right. So how many of us are hearing
that the damage was done because
bad news traveled
faster.
So now we have to re-educate women. There is a specific time in those first couple of years of that right before menopause, when the ceases. That's fantastic time to have hormone replacement therapy, and it's very safe. And you should consider it if you are in pain and suffering and going through these changes that you cannot manage. it's an option, right? And
Mhm.
so we have to help women understand that. And again, there's going to be, just like every other condition, there's going to be women who want to do medical treatment, and there's going to be women who want to do it naturally. And both are okay, right? It's
Right.
whatever
Absolutely.
works for you to get through
Mhm.
that. And so again, that empowering, that being your own advocate, deciding what you want to do, but knowing how you can't do that if you don't have the proper information, right?
Right.
Not exposed to all of the options that are available to us. So that's really what I'm doing for the National Menopause Foundation, and trying to work on a national level to meet with all the women's health offices and all the agencies, national agencies, to say, hey, how are we going to address this for this huge
Mhm.
population as we go through? And again, people on hormone replacement therapy are kind of postponing the loss of bone, right? But we had a whole generation of women who had all that estrogen loss and now have severe osteoporosis. So
Mm.
we have a synergistic an alliance between the National Menopause Foundation and the National Osteoporosis Foundation. And we hope to be doing more together. And thank you for bringing it up. Again, I think another fantastic, useful place for women to go to build a community and be empowered.
Mhm. Oh, I think so. I
Well,
think, yeah,
go
that
ahead,
that
Bridget.
message is so important too, that is in there.
Absolutely.
For women, yeah, I mean, just knowledge is power. And women are starting to get frustrated with the lack of knowledge when they go to a doctor and say, I'm feeling this, I need help. So if you're not going to help me, I'll figure out how to do it myself. I
That's right.
will find the resources. And both of, the National Osteoporosis Foundation and the National Menopause Foundation are amazing resources. So if we can get that out there, because you're preaching to the choir with the two of us, but we want our thousands and thousands of
We'll just
listeners.
keep pushing it out
Yeah,
there. Yeah.
exactly.
Yeah.
To
Mhm.
understand you're not alone. You don't have to suffer alone. There are resources right online. Even during a pandemic, you can go online, you can learn what you need, and then talk to someone, maybe an online therapist or an online doctor that can help you. So the information you gave today is invaluable. We thank you
Mhm.
so
Yeah.
much for sharing it. Come back, please, anytime and talk
Thank
Yeah.
about
We'll
some
probably be
more.
contacting you. We'll be giving your,
Yes.
all of this out to
Please do.
people because,
Yeah, all of the information will be in the show notes and all the
Mhm.
links to the
That's it.
websites and
That's it.
Right.
everything like
Thank you
that.
guys for doing this. Like I said,
Oh, thank you. If
the
people
more we
ask in
talk
our
about it,
group,
the better.
yes, when they ask in our group, we're going to be putting your
The
websites
website,
out there. Yes.
all the information we can. But
Yeah.
thank you so much, Claire, for taking the time to
Thank you.
Yeah.
talk to
Thank you.
us, to educate our listeners, and just for what you're doing. Thank you
Oh,
so
thank
Mhm.
you.
much.